I
Hi everyone, I am Francesca Cerutti and I would like to welcome you to this webinar developed in collaboration with Fanta Dental. The topic will be how to simplify our endodontic life, because I think it's something that can be interesting for everyone from the GP to the most experienced endodontist. So I recorded a short video that I would like to share with you. Enjoy the vision and see you later.
Francesca Cerutti. Like to discuss with one. I am just I would like to discuss ways to simplify a endodontic treat, because we all I think would like to with our farming. It means to make something less complicated and therefore easy.
I'm sorry, the beautiful of live streaming is that sometimes we have to fix problems live. So there's a little problem with the audio. We're going to fix it and we'll be right back in some minutes. Thank you for waiting.
Hi everyone, I am Francesca Cerutti. Hi everyone, I am Francesca Cerutti. Today I would like to discuss with you about ways to simplify endodontic treatment because we all, I think, would like to simplify the way we treat our patient. But what does simplify mean? It means to make something less complicated and therefore easier to understand, or in our case, easier to do. When we do an endodontic treatment, in general, we are going through a perilous path, and we always have the risk of facing some obstacles that make our day extremely harder. So, I would like to pass you some concepts that can help you in making your endodontic life way easier. We all know that for going from A to B, there are several paths and several ways. Some are straighter than others. Others are more artistic, maybe to see, but less ergonomic. And some others completely make no sense because they make our work more difficult and less predictable. So I would like to share with you which is the straight path from A to B. But why do we choose one path comparing it to another one? It all depends on our training, the effort that we want to make, the armamentarium that we have in our practice, the time we want to dedicate to the treatment, and obviously, which is the cost of the treatment for the patients and for us. It's clear that if we want to climb a mountain and we want to go with our bare hands, it will take us a lot of preparation, and maybe if we are not extremely prepared, it will end up in a disaster. And the other way, if we want to go extremely straight and with no effort, we can take an helicopter. Obviously, going with the manual solution in endodontics means to have a lot of training because it's not easy to manage a whole endodontic treatment with only manual instrument. We will make a lot of effort because it will be long, it will be difficult. We will need a small armamentarium because we just need some hand files and irrigant and materials to just do the endodontic obturation, but at what cost? It's cheap in terms of money, it's not cheap at all in terms of time, because if you ask the old endodontists that were used to do the endodontic treatment only with manual instrument, how many appointments they needed in order to finish a therapy, you will be surprised. It was a lot of time and a lot of effort. On the other hand, we have the rotary solutions that are extremely more time saving. Obviously, they cost more than only manual instruments, and they require a larger armamentarium because we need at least an endodontic motor in order to make the files rotate. We will do a small effort because obviously the file is doing the hard job. And yes, we will need training because we need training in order to know how to manage correctly the rotary files. Anyway, with manual files, with rotary files, we need to establish a glide path if we want to go from the coronal to the apical third without problems, without ledges, without any kind of deviation from the original path of the root canal. And I'm not the one saying it, because if you look at the literature, you see that, for example, in this article, they say that rotary files deviate less from the original path in S-shaped canals than manual files, and they use extremely well-trained endodontists to do the tests. So it's not like the dental student using rotary or manual file. It's someone who practices endodontist a lot. This other article also described the kind of file we need in order to do a good glide path, with a short pitch, small tip, and a small taper, in order to penetrate easily into the root canal and to follow the original path of the canal without changing dramatically the shape of the canal itself. Another article says that a glide path helps preserving the original anatomy of the tooth because they tried to do the endodontic therapy in simulated canals with or without glide path with the same instrument. And the same instrument performed better when there was a glide path before because the tip of the instrument just followed smoothly the path from the coronal to the apical third of the tooth. Another article says that night-eye glide paths leads to less postoperative pain than a stainless steel glide path. So if we are using night-eye instruments, we are going to probably have less postoperative pain in our patients. Why? Because most of the rotary file have these spires designed in order to take the debris and the pulp remnants outside the root canal while they are shaping, while they are penetrating into the corona, middle, and apical third. On the other hand, stainless steel are just pushing the debris outside the root canal into the periodontium. So it's obvious that they will end up in a higher postoperative pain. Another problem, if you do not do the glide path, is that probably your files are going to break if you don't use them in the correct way. You can use manual or rotary files, they all break sometimes. Without a glide path, it's easier for them to break. With a glide path, if you choose the correct sequence, it's a little bit harder. But what do we have to do? Preoperatively, we have to decide and establish what kind of tooth we are treating, because in wide and easy canals, so those canals that are extremely straight and no curvatures and the broad diameters, it's obvious that in such anatomy, the glide path will not make the difference because we can arrive straight to the apex with the rotary files of a large taper. So it's not the case, but when we are in regular case with straight or slightly curved canals, and even more when we are in narrow and difficult cases, so those canals that are extremely thin or calcified, or canals with a single or double curvatures, there is where the glide paths make the real difference in the outcome of our treatment and the outcome of our shaping, because we have to try to maintain as much as possible the original shape of the root canal in order to preserve the dentine, because we always have to remember that yes, we do an endodontic treatment, but that tooth has to be restored later, and the more dentine we preserve, the better the outcome will be, and the restoration maybe will be more conservative, so we can make an inlay or an onlay instead of a crown, for example. And this for our patients is vital because in that situation, we are buying time for their teeth to last longer in the mouth. So we are doing a service to our patient, just saving some dentine. This is something we always have to remember when we do an endodontic and restorative treatment. Independently from the technique you choose, scout the coronal two-thirds of the root canal before trying to get to the apex. You can do it with manual files, you can do it with rotary file, do it. I don't care what you're using, but please do it, because this is creating a pre-enlargement that will allow your instruments to encounter less resistance while penetrating into the root canal, and so you will decrease the risk of taper lock and breakage of the instrument, or the risk of, for example, creating a wrong path. So while scouting the coronal two-thirds of the canal, we pass from this situation, so it's a narrow path with like rocks and leaves, and everything is not extremely easy to walk on, to this situation in which there is a smooth road that takes us straightly where we want to go. So you will agree with me that this situation is much easier to manage than the situation we saw before. How do we do shaping in wide and easy cases? As I said before, we can go straightly with our right path with the number 10K file straight to the working length, and then we will have to transfer that working length to the sequence. In the cases I'm showing you, I use the essential kit developed by Fanta with Style Italiano and Endodontics, so I will talk about these kind of instruments. And in this case, we will we will bring straight to the working lamp the 1303, 2004, 2506, and if the root canal allows us to do it, but we are talking about wide and easy canals, so it's like 100% the case, we will use also the 3504 for finishing and maybe a larger instrument if the diameter of our apex is larger than 35, which is extremely possible in these cases. For example, here, the final diameter was like 80. So what did I do? I removed the gutta percha that was practically no sealing anything. It's just like a gutta percha point just thrown into the space of that root canal. I shaped, cleaned, filled, made an apical plug with MTA and the back filling with one gutta percha. And then the patient wanted to bleach the teeth, so I put a provisional restoration and we will do the bleaching later. The approach changes a little when we consider normal cases, so with straight or slightly curved canals. What do we have to do in addition? We have to do the pre-flaring of the coronal two-thirds with the number 10K file and then with the purple and red instrument of the essential kit. We can jump the step of the yellow if we want to. If we don't want to, we can just put the yellow between the purple and the red and we are fine. What do? We just work short respect to the estimated working length in order to pre-enlarge coronally the root canal. In this way, our 10K file used later will go straight to the working length and then we can bring straight to the working length the purple and the red with no effort. As I said before, if we don't feel confident in jumping from the 13 to the 25 step, we can just use the 20 in the middle. There is no problem. And even in this case, if the root canal anatomy allows us to do, we can also finish with the 3504. There is no problem at all. This is a case of a regular shape. You see these lower incisors. You see there is one that's extremely dyschromic. The patient was sent to me from a colleague asking me to treat both incisors because he saw the X-ray. There was a large lesion and both teeth were not responding to the vitality test, but I'm not sure that is due to both. So I spoke to the colleague, I spoke to the patient, and together we decided just to treat for first the tooth that was evidently dyschromic. And it was no doubt that this tooth was necrotic. In fact, it was. So I isolated it. I did the most conservative access cavity I could do, considering also the fact that the tooth was rotated, so it was not extremely easy to do this kind of access cavity. Then I went with my files. I was able to bring to the working length the 10K file, and then I transferred that working length to the 13, to the 20, and to the 25. I just did my irrigation and my filling. And as you can see, 4 months later, the lesion is healing and the other tooth started responding again to the vitality test. So never trust too much vitality test and if possible try to delay the endodontic treatment of the nearby teeth in these cases because when there is one that is with no doubt responsible for a lesion, maybe also the others can be involved, but start treating that. Give a chance to the other teeth. In this case, things are going well, and I'll keep you updated on what will be next in the next month. Or in this other case, another regular tooth. The canals are not particularly curved, so I can go with no problem with my 10K files. I did my endodontic treatment. I finished with a 2506 in the measure roots and with a 3504 in the distal root. I did my endodontic obturation. I did the restoration, and then I sent the patient to the neurosurgeon in order to remove the cyst that is mesial to the molar that I treated endodontically. He had no idea he had this kind of lesion, but we saw it when we did the urgency endodontic treatment for the second lower molar, and so he had it removed. Another case of a molar sent me by a colleague that was not, he didn't feel just confident in treating it because he said the canals were quite narrow, he could not achieve a good anesthesia, the patient was extremely in pain. So I treated it with the sequence that I told you before, with zero problems. And as you see, there is a middle mesial canal, so we have three root canals in the major root and just two in the distal root. And as you can see from the color of my gutta-percha point, in the mesolingual and in the distal, my apex was 40. So I went with and large diameter of instruments with no problems. In this case, I used the single cone and bioceramic sealer for the obturation, but the obturation in this case was not influenced because I had a good shaping from the crown to the apex, so I tried to be as conservative as possible considering the shape of the major root of the first lower molar, and it seems that everything is going fine. Things change a bit when we consider the narrow and difficult cases because we have to spend more time in the pre-flaring phase. We have to do the pre-flaring of the corona two-thirds with almost all of the sequence of the instruments because we use 10K file, 1303, 2004, 2506. And then, if we can reach to the apex with the 10K file, we establish the glide path and we go to the working length. If we cannot, we just repeat the pre-flaring phase, going a little deeper until we can reach the glide path with no effort. And just in that moment, we can go with the shaping and finishing phase. In narrow and difficult case, maybe you are not going to the 3504, we can stop to the 2004 or 2506. As in this case, for example, of a second lower molar, the patient had a pulpitis, I did the endodontic treatment, then before restoring, I asked to remove the wisdom tooth that was in just in a difficult position for me to do the restoration properly, and I did the restoration. No problems. In this case, I finished with 20 in the medials and 25 in the distal. Or this case, you see, it's a lower premolar. It seems easy, but it's not, because if you look at the X-ray carefully, you can see that at a certain point, at the middle of the root canal just like disappears. And if you look closer, you can see that this premolar has two separated roots. So this is a narrow and difficult case because those roots will be extremely thin in diameter, and we not want to alter that kind of anatomy. We want to preserve as much thin as possible. And so I chose to follow this sequence. The pre-flaring, then once I was able to reach to the working length with my 10K file, I did the glide path with the 1303, and then I finished with the 2004. As you can see, I did the isolation, multiple isolation, because there was a decay also on the distal tooth. So I wanted to do the both teeth in the same appointment if possible. I just opened my X cavity. You see there is clearly an smooth, and there are clearly two root canals, one buccal and one lingual. You see the working length I took with the 10K files, and then you see that I'm trying the fit of my gutta percha point in order to do the root canal filling. You see the canals that have been shaped and cleaned just before filling. And then you can see that I also had to do a direct pulp capping on the second lower premolar. So what did I do? I finished root canal therapy. I did the build-up of the first premolar, took an impression, and I called for some days later the patient in order to manage the direct restoration of the second premolar with the direct pulp capping, and in order to do the cementation of the onlay I did on the first premolar. So as you can see, I did the direct restoration, and there is the onlay. And this is the final x-ray. As you can see, I tried to be as conservative as possible in the management of this kind of tooth because the patient is not young, he has some problems because there are some molars missing, so I want those premolars to resist as much as possible to the occlusal loads. Here is another case that is treated with the essential kit by Francesca Italiano Endodontics. It's a regular case because it's a second lower premolar with just one root and one root canal, and the root canal has no particularly pronounced curvatures, so I'm kind of confident that I can treat it with the normal protocol. I removed the decay, did a pre-flaring, and then I went to the working land with a number 10 K file. I used the C handle to hold the file in order to have an improved visual field of what I was doing because the patient wasn't opening very much the mouth, so I thought better with the C handle. And then I brought to the working land the 1303 file, followed by the 2506. I checked the debris on the spires because I wanted to have a visual gauging and I wanted to be sure that I had effectively shaped the apical third of the tooth. And then I used my usual irrigation protocol that alternates irrigation and activation of the irrigant. And then you can see the root canal that has been obturated with gutta-percha in the apical third. And then what I'm doing, I'm taking care of the post-endodontic restoration. I am trying the fit of the post that I want to use. I didn't enlarge the post space too much because there was no need. This is a lower premolar with only one residual wall, and the thickness of this wall is inferior to 2.5 millimeters. So the guidelines suggest that this tooth will be better restored with a fiber post and then a cap coverage and a crown in this case. So I etched and then I'm applying the primer. I am using an active brushing technique in order to make the primer penetrate better into the dentinal tubules, and I'm leaving it alone for 1 minute. After this minute, I'm going to blow some air in order to make the solvent evaporate, and then I will be able to apply the bonding. And the bonding will be mixed with an activator in order to promote the light curing and to allow the part of the adhesive that are not directly activated by the light to self-cure. This is the tooth after the application of primer. And then I'm applying the bonding. I'm using the same technique, so active brushing with a very small brush in order to be able to reach all of the parts of the tooth. Sometimes I also use a different micro brush which is specifically designed for the application of adhesive into the root canal because it's thinner and longer and it helps to reach the deepest zones of the post space. And then I'm using a dual curing material in order to build the post. I apply the material, then I put the post that has already been salinized, and it has also been treated with a adhesive with an activator for the self-curing mode. Put the post, and then since the shape of the canal is oval and the post is round, I'm trying to position it in order to have the least number of voids possible. And then I'm applying the same materials I used to lute the fiber post in order to make the core build up. This is possible because the material is quite filled, so I have no particular problems in using it. I'm trying to remove the excesses before light curing, and then after that, I'm just polymerizing the material. Then I want to build up the proximal walls of these two. So what I'm gonna do is to cut the fiber post because I want at least 1 millimeter of composite that completely covers the post occlusally. So I'm cutting the part of the post that I do not need. I could have also done this before, but again, it's possible to do it also after you have luted the fiber post. And then I'm applying some adhesive again in order to condition the surface and to have a better adhesion. I remove the excesses of adhesive because in this way I'm saving time for later. I don't want to do this after having built the walls of the tooth. And then I'm using the same material in order to do the post-endodontic restoration. I can use this kind of material because in the end the tooth will be covered by a crown, so I have no problems of aesthetics, and I have no problems of this material being in direct contact with the oral fluids. So it's just something that will be covered by the zirconia or disarticulate crown. I'm just finishing with the going to fill the small voids that I have in the occlusal part, and then I'm like curing again. There are some bubbles on the surface, but this is not a problem because I will remove completely that part while finishing and smoothing the tooth. So this is something that doesn't worry me at all. I'm just checking the hardening of the material, and then I can just take my brush and do some finishing and try to give a little more tooth-like shape to this tooth. And then it will be ready for the preparation for the provisional crown, and in a second phase for a permanent crown.
What is another problem in endodontics, especially if you are working with a microscope? Then sometimes you just cannot see what you are doing. And in this case, Fanta helped us with a tool that is extremely nice because it allows us to just have a better and improved vision of the operative field while we are doing the scouting. Because sometimes when we work in molars, maybe in patients that are not opening too much, we put the file and with our hand in the middle we see nothing. So in this case, this kind of tool can really help us because as you can see now I'm setting it up, you just have to unscrew the tip of the handle, and inside of this handle you can put a manual K file, a spreader if you're using them, just anything small that can penetrate into the root canal. And when you are using K files, you can easily pre-bend them before putting them into the handle. In this case, you will not have to do it manually when you are working in the mouth. Later, I'm showing you a video in which I'm doing it manually while I'm working because I'm managing more root canals. But
If you are able to pre-bend it before, it's easier. And you can also position the stop in order to remember where the curvature is if you pre-curved the tip of the file. Because sometimes, as you are seeing in the video, when we are working with the hand, we are not seeing the access cavity and we are not seeing what we are doing. In this case, look at the transparent tooth. I'm just going to the working length with the 06K file, then with the 08, and then again with the 10. So I did all my glide path just up to the working length with the manual files, and I did it with an improved vision of the operative field I'm working in. And this is extremely useful, I think, in the posterior teeth, so molars and premolars. And it's nice that you can just connect the handle to your apex locator in order to just stop when you are at the working length. And I'll show you later a video in which I'm doing the very same thing. For example, in this case, the patient is a dentist. The tooth has huge periodontal problems, the second upper right molar, but he has pain while drinking, so he cannot drink anymore because anything cold will make him jump, and he wants the tooth to be treated. He's a colleague, so I'm not saying no. I'm doing the multiple isolation, and I just start removing the old composite filling that he had. As you can see, I'm using a multiplicator handpiece with a diamond coated burr, and I'm just starting from the old filling, and I'm going to remove it. And as you can see, part of the liner that was probably put in the deepest part of the restoration just jumped out when I touched it. So that's probably the reason why he has so much pain. But the tooth was extremely painful. He started having spontaneous pain. So I did the endodontic therapy. I just opened my access cavity, washed away some of the debris with sodium hypochlorite and a polypropylene cannula in order to follow more easily the path of the root canal and in order to bring a larger volume of irrigant to the apical parts of the canal. And as you can see, I'm just mounting on the C handle a 0.8K file. I didn't pre-bend it before, I'm doing it now. So it's quite simple to do, maybe it's less precise respect when you are doing it before putting the file into the handle. And as you can see, I'm proceeding with no problems into the root canals. You can do a watch winding motion and you can do a up and down motion. You can do both. There is no problem. You just have an improved operative field and an improved visual field of what you're doing. I connected the handle to the apex locator. You saw I was in the correct position, so I can just change root canal, and I'm doing the same thing on the other canals. I just do the normal things. As you can see now that I'm using a 10K file with my hands, the vision is completely different because I'm seeing my gloves. I'm not seeing what I'm doing and I'm seeing the access cavity. The problem is relative because I already recorded the working length before, but obviously with the handle I had a better vision. And this is the intraoperative X-ray with the gap touch points and the post-operative. Another case in which you can use with I think a lot of satisfaction the C handle is when you are treating extremely thin and calcified canals. In this case, I had to treat a necrotic tooth in a patient with a huge periodontal disease. As you see, there is a metal splint in order to keep the teeth connected one to another because they had a great mobility, but the patient was extremely motivated in keeping his teeth. So we went for the endodontic therapy. And as you can see, I pre-bent a 06 okay file, and I'm just trying to find the catch of where the root canal opening is. Once I found it with the 06K file, then I can jump to the 0.8. You see that I see perfectly what I'm doing. I'm proceeding into the root canal with the 0.6 file with no problems. I just go up to the rubber stop, I connected it to the dislocator, and then I can use my 10K file. I didn't even have to bend it because I was into a front tooth, so there was no need to bend it, but you can see that I can proceed easily up to the working length. Then I was at the working length, I applied the protocol, so I used the 1303 file with a picking motion. Then obviously between the files you just rinse with some sodium hypochlorite in order to keep the root canal clean. And then I went with the yellow, with the red, and I'm finishing my preparation with a 3504, which is a file that I like because most of the apexes have a diameter which is around 30, so I can just prepare the apex without enlarging further my coronal preparation because the 25 is 0.6 and the 35 is 0.4, so the taper is reduced. And this is the post-operative. So the take-home message is see more and stress less, because every time we can do something that improves our vision in dentistry in general, but in particular in endodontics, think about the loops or the loops associated with the light, or better with the operative microscope, everything that allows us seeing better puts us in a position of advantage and allows us doing a better job in a shorter time and with a lot more confidence and with less stress. So I think that will make our life extremely easier. Thank you very much, and if you have any question, I'm here to answer.
So thank you very much for watching the video with me. And if you have any questions, I will be more than happy to answer to you. I read in the comments that Dr. Cosmin said that he just started using these kind of files, and he thinks the purple one, the 1303, is a game changer. It's an extremely interesting instrument because it's flexible and the taper is very nice. It can penetrate smoothly in the root canals. The only advice I can give you is just to let it go. Do not push, do not apply pressure on it. So I think you will be extremely satisfied by using it. If there are no more questions, I just say you thank you and goodbye to the next webinar. Have a nice night.